everyone, welcome to the Explainer. Clock in, grab your scrubs, because today we are running a rapid-fire, high-stakes trauma-based shift. We're going to be focusing purely on high-yield clinical scenarios, the kind where every single second, and honestly, every single decision counts. We're decoding the strict protocols of acute thoracic and abdominal trauma management, navigating straight through the critical decision matrices that literally dictate life and death. So let's get into it. Here's the trauma board for this shift. First, tension pneumothorax protocols. Next, flail chest management. And finally, abdominal trauma diagnostics. Okay, let's dive into this. Section 1, tension pneumothorax protocols, immediate airway and breathing threats. All right, our first case hits the board right now. Picture this, we've got a 38-year-old female patient and she's undergoing a core needle biopsy of the right breast under general anesthesia. Suddenly, the ventilator alarms are going off. Her oxygen saturation is dropping fast. You auscultate and nothing. You hear absolutely zero breath sounds over that right lung. You palpate the trachea and it's shifted hard to the left. So what's your most appropriate management here? So the crucial point is recognizing this as an iatrogenic right-sided tension pneumothorax, directly triggered by that needle biopsy. The correct answer here is D. You absolutely cannot wait. This requires a strict, life-saving two-step sequence. Step 1 is emergency needle decompression. You've got to insert a large bore cannula into the right pleural space. Traditionally, we're talking the second intercostal space mid-clavicular line or the fifth intercostal space anterior to the mid-axillary line. That instantly relieves that lethal intrapleural pressure. But, you aren't done yet. Step 2, you have to follow that immediately with a definitive tube thoracostomy, so a formal chest tube, in that fifth intercostal space to get that lung fully re-expanded. Let's roll the next patient in seamlessly. We've got a 33-year-old male arriving after a pretty bad road traffic accident. He is really struggling to breathe. Right away, you notice distended neck veins, his trachea is shifted way over to the right, and there are absolutely no breath sounds over his left hemithorax. What's the immediate next step? The correct answer is D. We are literally looking at the late structural signs of obstructive shock here. Air is building up under immense pressure in that left pleural cavity, it's compressing the vena cava, and it's just completely crashing his venous return. We need an immediate emergency needle decompression via the second intercostal space, mid-clavicular line. Now, what you should really take away from this is a critical clinical dictum. Diagnosing a tension pneumothorax is purely clinical. If you delay this decompression just to grab a confirmatory chest x-ray in an unstable, cyanosed patient, well, that is a lethal triage error that leads straight to cardiac arrest. No x-rays, just act. Okay, now that we know the what and the when, let's shift to the how. We're moving from pathophysiology straight into structural anatomy. Which of these statements regarding chest intubation anatomy is actually correct? And this brilliantly illustrates the correct answer, which is E. The chest tube should be inserted into the lower border of the intercostal space. Why? Because you absolutely must pass the tube over the superior border of the lower rib. If you aim too high, you risk severing the intercostal neurovascular bundle, the vein, artery, and nerve. That whole bundle sits hidden right in the costal groove along the inferior border of the upper rib. You definitely want to avoid that. Moving right along. Section 2, flail chest management. Complex structural thoracic trauma. Here's a really interesting mechanical puzzle. A flail chest happens when 3 or more adjacent ribs are fractured in 2 or more places. This basically isolates a whole section of the chest wall. So how does this free-floating segment actually move during respiration? The answer is D. It has an inward movement during inspiration and an outward movement during expiration. We call this paradoxical motion because it does the exact opposite of the rest of the intact thoracic cage. Let's break down the biomechanics. When you breathe in, your chest expands, right? That creates negative intrapleural pressure to draw air in. But that negative pressure acts like a vacuum on the unanchored flail segment, just sucking it inward. Then, when you breathe out, the positive pressure needed to push air out actually pushes that unanchored floating segment outward. It's totally backward. Now, let's complicate the picture with a progressive hidden threat. You've got a 33-year-old male with a flail chest in your care. Initially, a tension pneumothorax is totally ruled out. But over the next few hours, he develops severe, labored breathing. Even though he's getting proper pain meds, his oxygen saturation is dangerously low, and critically, it's not improving at all, even with high-flow oxygen. What is your next step? The correct answer is E. Now, what's really interesting about this slide is understanding the true enemy here. The fractured ribs are painful for sure, but the actual driver of this progressive respiratory failure is an underlying pulmonary contusion. The blunt trauma literally bruised the lung tissue itself. As hours pass, that bruised parenchyma suffers from alveolar hemorrhage and edema. It fills up with fluid, creating a massive intrapulmonary shunt and a severe ventilation perfusion mismatch. Simple oxygen therapy just can't fix this because the oxygen physically cannot reach the blood. This patient needs immediate endotracheal intubation and mechanical ventilation using PEEP, positive end expiratory pressure, to force those fluid-filled alveoli open and get that gas exchange working again. Next up, we've got a complex dual injury case. A 32-year-old male took a massive blunt impact. On the left side, he has a visible flail segment moving paradoxically. On the right side, you note dullness to percussion and totally absent breath sounds. Yet, surprisingly, his hemodynamics are currently stable, and he's maintaining an excellent oxygen saturation of 97%. So, how do you manage this highly specific clinical picture? The answer is B. Let's walk through the triage logic here because it's fascinating. Why are we ruling out intubation? Well, because his oxygen is sitting at a very comfortable 97%. He's ventilating adequately all on his own. The dullness to percussion on the right indicates a right-sided hemothorax, meaning blood is pooling in the pleural space, so we definitely need chest intubation, a chest tube, on the right side to drain it. But for the left-sided flail chest, we just need to control the severe pain so we can keep breathing and coughing effectively. A regional paravertebral block is absolutely perfect here. It provides targeted, excellent pain relief without the systemic respiratory depression that heavy IV opioids would cause. All right, final zone, Section 3, Abdominal Trauma Diagnostics, Critical Triage and Intervention. Let's start with a foundational diagnostic question. Say you have an unstable blunt trauma patient where a CT scan is just impossible. We use a diagnostic peritoneal lavage, or DPL. We instill warmed fluid into the abdomen, drain it, and send it straight to the lab. Which quantitative cell count threshold indicates a positive DPL, mandating an urgent exploratory laparotomy? Let's move to the correct answer, E, and see how this builds. We're looking for 100,000 red blood cells per milliliter. Here are the absolute thresholds you just have to memorize. Greater than 100,000 RBCs per ml means significant vascular injury and intraperitoneal hemorrhage. But look at the white blood cells. If you see greater than 500 WBCs per ml, you're looking at a delayed inflammatory response, often from a hollow viscous perforation, like a ruptured bowel. And of course, if you insert the catheter and immediately aspirate 10 milliliters or more of frank, non-clotting blood, you just skip the lab entirely. That patient goes straight to the operating room. Now, numbers are great, but we really have to understand the functional limitations of our tools. Take a look at this question regarding the broader characteristics of the DPL procedure. Which statement is clinically true here? The true statement is A, which reinforces our 100,000 RBC threshold. But let's really detail the vital blind spots of this invasive tool. DPL is incredibly sensitive for detecting free blood just sloshing around the peritoneal cavity. But its massive limitation? It is entirely blind to retroperitoneal injuries, and it cannot tell you which specific solid organ is bleeding. That's exactly why if the patient is stable, a CT scan is always the gold standard. Another critical triage shift you absolutely must know. If the mechanism of injury switches from blunt trauma to a penetrating stab wound, the threshold for a positive DPL drops drastically from 100,000 all the way down to just 10,000 RBCs per ml. And that's due to the high risk of bowel or diaphragm injury. Okay, we've reached our final case, and this patient is teetering right on the quantitative edge of the stability definition. It's a blunt abdominal trauma case. The blood pressure is exactly 90/60, and the pulse is 110 beats per minute. Which investigation will reliably exclude intra-abdominal injury in this specific patient? The correct answer is D, a CT scan with contrast. And here is why. By definition, this patient is hemodynamically stable. The systolic is at or above 90, and the heart rate is below 120. Because they're stable, we bypass fast exams and DPLs, which, as we just talked about, only detect generic free fluid. We need the high-resolution structural detail of a contrast CT to definitively rule out specific solid organ lacerations or hidden retroperitoneal bleeds. But I want to leave you with this final provocative thought. We just defined this patient as stable. But what happens if, right as they're sliding into that CT scanner, their systolic pressure drops by just 5 points? Suddenly, they are unstable. That single 5-point drop means the entire diagnostic algorithm instantly flips. The CT scan is aborted, and you are right back to an emergency fast scan or DPL. The trauma bay is dynamic, and your understanding of these protocols has to be just as adaptable. Keep these visual frameworks locked in, and I will see you on the next explainer.